Okay, first let me apologize because I'm in a hotel where the internet is broken. So I'm going to do this with the slide presentation that I sent you, but I'm doing it blind. So here we go. Let's skip to the second slide. No, I can't. Okay. That's the conflicts, and let me just mention that I have got plenty of conflicts with virtually every company that's doing carotid stenting, so I am conflicted. I was also an investigator in the NASA trial. That's not really a conflict, but so I'm definitely conflicted, but I'll give you my honest opinion, and I'll give you some data. So the next slide is a picture of a carotid, and the carotid endarterectomy is, of course, the most studied operation in the history of neurosurgery. We know who is high risk, what is its role, and then carotid stenting. Why is the data so confusing? Why is the CREST data different from all the European data? And what is the role for carotid stenting? And what is its future? So the next slide is personal experience. And you can see that I was involved in, I guess, every single carotid trial that occurred in this country in the United States, including CREST, where I was PI for neurosurgery. The next slide, just the current therapeutic options, which we all know full well. Stenting, medical therapy, and endarterectomy. Important issues for us to consider: what is high risk for stenting? Should we treat elderly patients with stents? Should we treat symptomatic patients with stents? Are the two procedures complementary? And then the next slide, assuming a patient assuming the risk for these two procedures is the same, why should stenting be the first choice? And it's very simple. It's less invasive. There's no general anesthesia required, and yes, it's true that Bob does use local anesthesia, but he's one of the few surgeons in the country that does that. Stenting is faster and easier. By the time Dr. Harbaugh does his endarterectomy, I can do 2 carotid stents. Endarterectomy is shorter hospital stay as a rule, and it will be less expensive as stents become more and more of a commodity. The next slide is just a mention of the risk factors for stenting are very different from those of endarterectomy. Carotid endarterectomy risk factors are well known. Just look at the exclusions from NASA. You know who's high risk for carotid endarterectomy. We're still learning who's really high risk for carotid stenting. The next slide is just a review of some of the things we think about when we're making a decision for carotid stenting, and mostly they're anatomic factors having to do with the arch anatomy and the perilesional anatomy, and then there are some clinical factors, associated medical conditions and intolerance to antiplatelet agents and so on. Now, if we take a quick look at the European trials, we don't have time to go through all of them, but I'll tell you what we've learned from the European trials are 3 basic things. One is that experience counts. And if you look at the experience in the European trials compared to that in the CREST trial, it is absolutely de minimis. So we could go through lots of reasons, like, for example, 5% of the patients in the EVA 3S trial actually had to be aborted and taken for surgery. And what that tells you, and what we know, is that most of the investigators in the EVA 3S trial were actually vascular surgeons learning to do carotid stenting. You could enter patients in the trial after having done only 5 carotid stents. So it's a very different group of people than what we had in CREST. And even CREST was early learning. So the other thing is that embolic protection helps. In all the European trials, it was not mandated, and just keep that in mind as we look at the CREST data in a minute. And myocardial infarction is bad. We learned that from CREST. It wasn't apparent in the European trials. If we look at the evolution in medical technology, it's clear no trial has all the answers. Positive trials confirm our hypotheses. Negative trials tell us what to change. And we have 60 years of learning in carotid endarterectomy and only 15 years in carotid stenting. And the CREST trial was really designed after only 4 to 5 years of experience with carotid stenting. So then the results of the New England Journal that were published last May reflect the intent to treat NIH analysis, and just briefly mentioning the primary endpoint, peri-procedural stroke, myocardial infarction, and death, and post-procedural stroke up to 4 years. Important definition is myocardial infarction. We did look for myocardial infarctions, and it had to be a real MI. It had to be an elevation of cardiac enzymes to double the normal, or chest pain, or EKG evidence. Either chest pain or EKG evidence of ischemia. So these were real MIs. Secondary aims were differential efficacy by symptomatic status, sex, and age, and we'll take a look at those. Remember, the next slide is that the CREST trial was done with early first-generation technology. The Acculink stent and the Accunet filter, these were the first generation. The results reported in the New England Journal, everyone's probably familiar with, 7.2 versus 6.8, not significant difference between the two procedures. And then the next slide just mentions that there was no real interaction for symptomatic status or sex. The next slide looks at age, where there was a trend, but if you look at the data, you'll see two dotted red lines. Basically, between age 60 and age 80, there was no significant difference in terms of age. If you went over 80, there was a difference favoring carotid endarterectomy. In summary, we found that minor strokes were more common in stenting and MIs were more common in MI. Now let's take a little bit of a look. Let's skip the next slide and go to the PMA analysis in CREST. And the difference is that the PMA analysis, one, it is in standard surgical risk patients, not high risk, but standard risk. Importantly, the PMA analysis is an intent to treat analysis because the FDA really wants to know only what happens when you do the procedure. So this is a per protocol analysis as opposed to the intent to treat analysis in the NIH study. So let's look at the per protocol analysis. First, just to mention that over time, endarterectomy results have improved. If you look back into the late 70s, there was a report of endarterectomy complication rates in the 20% range and greater. The same thing was true, poorer results for stenting early on, and endarterectomy results have improved over time, as have carotid stent results. What is important, if you look in the bottom of this slide, outcomes of CAS trials over time, the yellow in the bottom, enrollment from 2004 through 2004, 5.7% M&M in the stent patients. From 2005 to 2008, 1.1%. So that's a significant improvement in the results in the second half of the trial. So now let's go to the PMA analysis and just take a quick look. If we look at the composite endpoint, it was really the same, death, stroke, and MI, but in the analysis for the FDA, it was only out to 1 year. Now let's look at the FDA analysis, which is a non-inferiority analysis, as opposed to the NIH analysis, which was a superiority analysis. And let's look at the results in this non-inferiority analysis. Overall, 7.1 versus 6.6, and the p-value is significant, which means that the stenting is not inferior to endarterectomy. So not inferior if the p-value is significant. So if you look at, I think another very, very important slide is this one. If you looked at the group of patients, this is entitled, Does Embolic Protection Matter? And at the bottom of this, you see in yellow, if Accunet was used, the embolic protection device was used, then the results between carotid stenting and carotid endarterectomy were exactly the same. If it was not used, if there was no embolic protection used, then there was a greater than 20% morbidity and mortality in the stent arm. So a big difference if embolic protection was used. The next slide is periprocedural death, stroke, and MI. Again, you see that stenting is not inferior to endarterectomy. The next slide is, does stenting improve with experience? And this is what gets interesting. If you look at the results on the left, from 2000 to 2004, you can see a dramatic improvement in the results from 2004 through 2008. The next slide looks at death or major stroke rates. And again, you see a dramatic decrease in the M&M for stenting in the 2004 to 2008 range. And this is for symptomatic patients. And look at that in 2007 and 8, 0 and 0. And then does it improve with experience? Look at death and any stroke rates, and you see again an improvement from 2004 through 2008. The next slide is death or any stroke rate in symptomatic patients. Again, a significant improvement in the latter years of the CREST trial. If you look at the 6-month data, you see that according to the NIH data, the stroke patients were equivalent in their NIH stroke scores at 6 months to the endarterectomy patients who had minor strokes. And then it's not quite as good with the modified Rankin, but still a significant improvement, so that they're very close and no significant difference at 6 months in terms of neurologic residual. This is an important slide. The next slide is death, stroke, and MI within 30 days, and this just summarizes the whole thing. If you look at the third line from the bottom, major stroke, there was no significant difference. The differences all occurred in minor stroke and in myocardial infarction, where minor stroke was more common in stenting, myocardial infarction more common in surgery. The next slide, why myocardial infarction as a primary endpoint. This is a very important slide because it shows you that if you had a myocardial infarction during a procedure at 4 years, you had only a 75% survival. If you had a stroke, then if you had a minor stroke, then 94% of the patients were still alive at 4 years. So the point here is that myocardial infarction is a very, very important predictor of longevity and mortality. So it is important, and we should be looking at it. Now, the next slide is the outcomes balance for these two procedures, and it shows, again, decreasing rates of adverse events for stenting over time, similar rates for stenting and endarterectomy in the second half. There's no real difference in the second half. Minor strokes more common in stenting. Myocardial infarctions more common in endarterectomy, and a definite relationship to mortality. And that's really why the results overall are equivalent. Other pre-specified endpoints. We looked at symptomatic status and age, and acute success, target lesion revascularization, and access site complications and cranial nerve injuries. Just briefly looking at the symptomatic or octogenarian status, you can see in this slide that there is absolutely no significant difference between endarterectomy and any of these subgroups in the trial. The next is freedom from target lesion revascularization. Again, they're pretty much equivalent throughout the full year. The next slide, lower access site complications for sure in carotid stenting than in endarterectomy. And we remember from the NASA trial that a wound hematoma was indeed a risk factor for stroke. So a wound hematoma is significant. Infection, as you see, far more common with endarterectomy, et cetera. So access site complications. And of course, no cranial nerve injuries with carotid stenting as opposed to a 5% rate with carotid endarterectomy. Mortality, similar mortality out to 4 years is the next slide. And then the next slide, similar freedom from ipsilateral stroke out to 4 years. No real difference. The curves are superimposed. The conclusions really are that stenting is complementary to endarterectomy. The results appear to be getting better and better with carotid stenting. We still have more minor strokes with stenting, but that difference appears to be going down. It's another hurdle we have to climb. Clearly, MI is more common with surgery. I don't know whether it's more common with local anesthesia, but again, probably 90% of endarterectomies in this country are done under general anesthesia. So the point here is that each procedure has a place. Stenting is improving with experience and judgment. New technology is going to further improve carotid stenting, And interestingly, endarterectomy continues to improve. The results in this trial were spectacular for endarterectomy as they were for carotid stenting. So I think the final slide, it should no longer be endarterectomy or carotid stent. It should now be endarterectomy and carotid stent. And I think that's the message that we should drive home. These two procedures are complementary. They both have a place. They're both helping us to improve the results for patients with carotid surgery. Thank you.
Thank you, Dr. Hopkins. That was a terrific review of the data on carotid stenting. We did have a question submitted for you if you're still on the line.
Yeah, I'm here.
Great. The question is, which distal protection device do you think will be the wave of the future?
If I had to guess, I would guess that for straightforward lesions, asymptomatic patients with straightforward lesions, that filters, the various different types of filters will probably always play a role. I think that when you have an angry plaque, a recently symptomatic patient, I believe that proximal embolic protection will become the standard of care for those kinds of patients because it enables us to capture much more debris. We can stop the flow. I like to think of proximal embolic protection as similar to an endarterectomy in that you shut down the flow, do the procedure, aspirate out all the debris, and then reestablish flow. And I think that will be what we turn to as we have these more complicated lesions.
Great. There was another device-related question as well. Do you think that we'll see dissolvable stents for carotid disease?
Well, the coronary literature now is replete with examples of biodegradable stents, and I suspect that we will see that in the future. They are now able to make biodegradable stents that have lots of structural stability and then disappear over anywhere from 6 to 18 months. So I think that probably will come. The interesting thing is it's in the coronaries it's not different because the big bugaboo is restenosis, but in the carotids restenosis has not been much of an issue, and I think that's because it's such a high flow artery. But I do think biodegradable stents may have a role in the future. We'll just have to wait and see.
And a follow-up to that was, do you think there may be, say, bioengineered stents that may be lined with endothelium?
I think that's very possible, and I think that's really a great thought. Whether or not and when that'll come, I don't know.
I'll put this question out to all of the panelists. Are there any current or ongoing studies or plans for further studies to assess and assist in differentiating these procedures?
I can throw out one possibility, and that is that there is a trial in Europe called SPACE 2, which looks at all three modalities, medicine, surgery, and stenting. It is enrolling very slowly. There's a question of whether it'll ever get completed. And there's a transcontinental trial called TACIT, which has not been able to obtain the funding so far. I think that study may have trouble getting going. There is a proposal for a CREST-2 trial that, again, would be a three-pronged trial looking at best medical therapy versus stenting versus surgery.
Terrific. And there's one final question that I think can be posed to all panelists, and I may offer an answer as well. How can neurosurgery gain a greater role in carotid disease? And just to throw my own 2 cents worth in there, I think that like a lot of disease processes where there may be cross-pollination from different specialties, that collaboration seems to be the key. That a lot of patients, a lot of referring physicians are really interested in an institutional ability to provide service and the recognition that that is quality service. In all likelihood, in major medical centers, those referrals are not being sent for a particular individual, but rather for a program. And the institution that can put together a program of good quality care, the collaboration between practitioners, is likely to get the lion's share of those referrals. We, for example, have put together a program that involves the screening help of our medical stroke neurologists and collaborative care or interventional care between interventional neuroradiology, neurosurgery, and vascular surgery. I don't know if the other panelists have a thought on that process as well.
Yeah, I would agree with that approach. I mean, personally, I think that treating asymptomatic stenosis is likely to go away as they're going to be managed medically. And therefore, I think the critical collaboration is with the stroke neurologists. I think the other thing that I think is very important is that neurosurgery really needs to focus on the endovascular treatment as well. It shouldn't be the situation where, you know, the neurosurgeons do the surgery and somebody else does the endovascular treatment. So I think, you know, having that comprehensive stroke program is the key, and that certainly worked very well here.
I agree.
I think I just throw in that I think it's unlikely that asymptomatic patient treatment is going to go away in the near future, because today well over 70% of all the patients undergoing carotid endarterectomy are asymptomatic patients treated by vascular surgeons most of the time. And so I think that's really the standard of care in this country today, and I don't think that's going to go away so quickly. It may be that a major trial could change that, but right now we don't have the data to say that it should go away. What we're focusing on in our shop is really looking carefully at the plaque morphology, and we're trying to study it using a couple of modalities. One is MRI, 2D black blood studies looking at plaque morphology, which has been very helpful. The other thing that we're doing is using TCD, and there's a fair amount of European data suggesting that patients that have active hits on TCD are patients that have active plaques and should be treated. So that I think the more we learn about the disease, the better, and as we learn more about the plaque morphology, we can make better selections on these asymptomatic patients.
I rarely agree with Nick, but I have to agree with Nick on this, that
no.
the degree of stenosis is a very poor proxy for the dangerous plaque. And what we really need to do is be able to pick out that small subset of the asymptomatic patients who are at real risk and need to have the plaque addressed. And we're using the same modalities as Nick mentioned.